I'd like to welcome Dr. Karem Harth, who's a rising star in venous disease. She's the director of the Center for Comprehensive Venous Care and the co-director of the vascular laboratories at University Hospitals in Cleveland Medical Center in Cleveland, Ohio. Thank you for agreeing to do this podcast.
Yes, well, thanks so much for the invitation. It's really an honor to be here and share some of the cases here in complex venous disease.
So over the last 20 years, we've been privileged to witness an endovenous revolution that has transformed our field and benefited our patients. Recently, a whole new set of venous thrombectomy devices has been introduced, which Karem Harth has been exploring. Could you tell us a little bit about these technologies?
Yes, so as you mentioned, for a long time, I think many of us felt like venous disease was an orphan disease in the sense of reconstruction of deep venous system and thrombotic patients and chronically occluded patients, particularly those with good indications to do an intervention like venous ulceration and venous claudication patients. They really were left with not very many good options. And in the era of current day, let's say, starting 2019, we had dedicated venous stenting, which was really a great technological advance for our patients. And certainly multiple thrombectomy devices have also come to the forefront, both mechanical and suction based. And with the rise of stenting, we have the challenge of, well, what happens when these stents fail? We have to understand why they fail. A lot of it relates to anatomic factors, technical factors, techniques in using and deploying stents, particularly related or surrounding the idea of to use or not use IVUS, which I think is certainly crucial in patients to understand appropriate sizing. And when it comes to stent failures, we really, until recently, we really were left with suboptimal approaches to recanalizing these stents. If you caught them early enough, well, you can lyse and maybe use some of the suction devices and balloon angioplasty and maybe reline or address the inflow or outflow problems. But there hasn't really been therapies to allow us to clear the stent to a good lumen. I think for me, the biggest thing I obsess about is creating a channel that's as close to the thrombus-free lumen as possible before I put a stent. I think that's really critical in my mind to having the good long-term outcome. But all of these things really, kind of the summary of that is that we have so many things to learn, and I think the device advancements are really allowing us to treat some of these complex problems little by little. I think dedicated venous devices are so important. I think taking arterial devices into the venous space has shown us that it's not the same system. They just don't work as well. So it's really exciting to finally have this sort of device explosion, if you would, for our venous patients. And now of course, our role is now to see which ones we need to use and how to best use them in the appropriate setting.
Okay, so can you talk about some of your experience with the new Inari Revcore device?
Sure. I'm happy to. Why don't I proceed with a little bit of a presentation here? So let me share my screen. Okay. So hopefully that is visible, where you can see that well. All right. So I'm going to talk about the Revcore device, and it's finally a dedicated device for in-stent thrombosis. So the Revcore device is currently the only mechanical thrombectomy device for venous stent thrombosis. It is designed to remove the thrombus with a unique element that addresses the full range of chronicity. You can deploy this across various sizes from 6 to 20 millimeters. And that's where we have this right size every time. We have an ability to control the device to allow us to expand or contract depending on the size of the lumen you're working on. And it has very good control from the user standpoint in terms of torque, advancement, and closing of the device. So this is an image here of the device, the handlebar. has a TUI almost, if you would, that you can upsize towards the plus sign and bring down the coring element of the Revcore device. And you can tell what size you're at by following the lower part of the handlebar that gets you from 6 to 20 millimeters, and it has a side port for simultaneous venography while you're working. And so this is that unique element which contracts and expands from 6 to 20 millimeter diameter. The handle has these tick marks that allow you to know where you're working in terms of the diameter ranging from 6 to 20 millimeters. So at the 2 mark, it's closer to the 6 millimeter mark. I'm sorry, at the 0 mark, it's fully collapsed. And as you get to the 4 mark, you're at the 20 millimeter diameter of expansion of the device. The knob actually helps you get to that diameter. And then the shaft allows for retracting, advancing, torquing. So you can go in an antegrade, retrograde fashion. It goes through a 12 French sheath and is an 035 capable device with an 80 centimeter working length. So I think that, the best way to show how this device works is really provide a case scenario. So this is a gentleman I recently took care of, which was fairly complicated. He's a 58-year-old gentleman who has a BMI of 40. He has a history of superficial venous interventions at an outside facility, and most recently underwent bilateral iliac stenting. He never had a prior DVT, and it ended up with a 20 millimeter stents in both of his iliac veins, which was unfortunate. I don't think that's, when I see something like this, I question whether it was needed to begin with. Nevertheless, so presumably this was for a non-thrombotic iliac vein lesion. So nevertheless, within about a month, 4 to 5 weeks after this event, he ended up with a left femoral vein DVT. This is the patient here when he presented to me after he was transferred for a second opinion with a failed attempt to recanalize and reintervene on this thrombosed stent. So here we see a CT scan. And if you look, the stents actually fall shy of the confluence. And on the left side, the stent is partially crushed. And they stay in the external iliac vein in terms of placement. Looking at the sagittal images, you could see how the stent here lands at the curvature of the pelvis. On both sides, here's the kinked stent. And really, that's no landing zone when you think about deep venous interventions and some of the things we know in terms of how to do the procedures correctly. You don't want to land at that 90-degree bend at the curvature of the pelvis, because you'll end up with a 90-degree stent along the vein. So here we see that the duplex shows that the leg has an acute DVT. So for this patient who was on heparin, I took him to the operating room. And for this approach, I do these under general. These are fairly complicated patients, and I think having three-way access is really the best way to do this. And you want to have a jugular and a popliteal approach, and you want to fully anticoagulate. My approach was to go from a popliteal and a jugular approach. One thing that adds to this case is complexity, which I didn't mention earlier, but was in the history there, is that he somehow also ended up with a femoral vein stent. So that is certainly leads to even more question about the appropriateness of this patient prior to seeing me. But nevertheless, this case, this is what we're faced with, and we have to try our best to improve this gentleman who was already with a significant advanced venous disease. So the popliteal approach was very challenging to get into. There was actually significant hematoma from previous access attempts, but we got through, and you could see that there was extensive DVT. Up halfway, almost close to the lesser trochanter, so probably the outflow portion of the superficial femoral vein, there's a thrombosed femoral vein stent that was placed in that location. I had tried to recanalize from a femoral vein, from a popliteal vein approach, but that was unsuccessful. So at this time, I went ahead and upsized my jugular approach and came down from the neck to get into the stent. So here we have the catheter coming in from the jugular approach and taking a picture with extensive DVT towards the profunda vein, and over here is the femoral vein. So I initially started off with suction thrombectomy because my goal was, if I was going to do anything, if I could potentially salvage the scenario, I wanted to have inflow. And the inflow, since I could not recanalize his femoral vein, the inflow for this patient was going to be profunda vein. And so that's where I decided to do suction thrombectomy to assure we could get profunda vein open. So once we got that open, there was still the challenge of the sort of positioning of this pelvic stent, and quite a bit of residual thrombus there. And this is where I think the Revcore device really shined and allowed me to do what I couldn't do with sort of more standard devices. I brought the Revcore device. I always use a Protrieve sheath. I think that's the best way to use this device. The Protrieve sheath, I'll show in a bit, is also a device that allows a temporary filter, if you would, to be deployed and retracted from the beginning to the end of the case. So you deploy it, use it during the case, and then it gets retrieved into the sheath. So I put the Revcore device through that Protrieve sheath, and the Protrieve sheath ends around the renal veins. I bring down the Revcore device and really just start to slowly upsize the device to what I think would be an acceptable diameter. In this case, it was a 20 mm stent, but of course it was challenging to get up to 20 because of that, not fracture, but the kink in the stent at the pelvic, the curvature of the pelvis. So I did balloon the stent up to about 20 mm. That helped me be more efficacious with the Revcore device. And then when we were done, we took a picture. If I could play it here, here we go. And so clearly, once I got the Revcore device, when I completed the case with the Revcore device, I got a much better luminal gain and really was able to clear quite a large amount of that thrombus that I couldn't otherwise. So here we have, when we started with a significant amount of thrombus, we have the profunda vein, which was cleared out with suction thrombectomy. The middle image where what was left, that was a challenge for Revcore. And at the end of Revcore, we have a nice venogram with good clearance. Of course, IVUS was, I use that for all of my venous cases, but this shows that post-Revcore, we certainly improved the diameter. We got better luminal gain of the stent, and that certainly the balloon angioplasty helped to straighten out that bend in the stent, and now we achieved good inflow from profunda. Here's an image of the Revcore device on the bottom of the screen here, bottom left, which shows you that it's a 26 French device. This is the sheath with the filter, if you would, fully deployed. And in the top right image here on the screen, we could see just some of the material and the debris that it captures. And this is after clearing it through the side port, where, you know, as you're working with this device and the Revcore device, as this material essentially embolizes and is captured by this sheath, you have to keep that clear, and so you can do that through that side port as you work your way through the stent or the occlusion. And so in this patient, at this point, I wanted to, we had a challenging scenario. We had a 20 mm stent. His common femoral vein was much larger than a 20 mm stent would be able to have good apposition to, because he was so dilated and his venous system was so congested, that I did not put a stent at this time. I did not revise it. I wanted to make sure, first of all, that things were going to stay open and that I was going to give this gentleman a good result. So I balloon angioplastied, cleared as much as I could, had good outflow, and managed this medically with Lovenox compression and a quick sort of a short-term follow-up with a 2-week visit and a CAT scan. We could see that his clinical improvement is ongoing. He's got less edema. He's able to ambulate. He has, you know, he's decreased his Villalta score, which was much higher pre-procedure, to now a 10 on the left. The stent here shows on the scan, the CT scan shows that the stent now it was opened up pretty well with the ballooning, but it still has a 90-degree end at the pelvic curvature. And duplex shows a nice phasic flow starting at the inlet of the stent and through the stent, which is consistent with his clinical improvement. But to me, in this case, I thought that the poor technical landing of that stent needed revision. His venous system had improved from a diameter standpoint, so there was some, he had venous, there was good decongestion from the procedure. And so I felt like now I could bring him back, revise it to avoid a future problem. And here we have the initial venogram also coming from a jugular approach, getting into profunda with, you could see where that 90-degree turn is of the stent, and revise this with overlapping stents down towards the common femoral vein. In this case, I was able to use an 18 because I wanted good apposition to the 20-millimeter stent, and had good inline flow from profunda. About 2 months on follow-up, his Villalta score continues to improve with the left going down to 7, and he's essentially pain-free. So again, this just shows the other side. He had the same technical problems, so I did revise, electively revise the other side, the right side, to avoid that 90-degree turn at the pelvis. And in these IVUS images, we could see how post-Revcore, when we left that first case, we still had some layering, if you would, of some thrombus that I wasn't able to clear. But I was, with anticoagulation, I was able to get that on our follow-up. IVUS was no longer there, so we had treated it medically. And the stent's going to come up here shortly. There's the stent with really not much layering, with good inflow. And then after stent revision, we have a nice apposition between the two stents with a good diameter through the stent, and not a lot of layering left from the prior intervention. So he's managed with Lovenox for another couple of weeks. I transitioned him to Eliquis, continued his compression therapy, and really managing what I think primarily for him also as a phlebial lymphedema type scenario. So I'm going to stop sharing here for now and see what questions may have, or what further discussions we can have from this. I know that was sort of a complex case, but certainly an interesting one. And I think we're a scenario where this device really shines, and I'm excited for this new therapy to give us these options to optimize reconstruction therapies.
So I agree with you. This is a fairly complicated case, especially with the femoral vein stent. That makes it a little more challenging, especially since all the inflow is coming to the profunda, which should be adequate. And it's done very well. You managed it very nicely. So where do you see this fitting in terms of, as compared to the other devices? When do you turn to this device as compared to some of the other pre-existing devices?
Yeah. So, you know, when I had, prior to this device, I must say, when I do suction thrombectomy, even if I use the largest diameter available, I'm always left with a layering, if you would, around the stent. And you can balloon that. It doesn't, you know, I'm not sure, we may be releasing some of the material distally, but I think that, you know, what are we left with? We're left with restenting, relining. And in that setting, I feel like, you know, we're just adding to, we're taking away from the lumen that we know is important to have a good result from a venous intervention standpoint. So if you keep relining stents, you're just making the channel smaller, and you're going to induce a state of venous hypertension, and the durability of that approach, I think, you know, is not optimal. And so for me, to consider relining or revising, I got to have the best, get as close to the native stent. And that's assuming somebody put in a good sized stent to begin with, right? I mean, we all know, we've seen scenarios where small, you know, like a 10 or an 8-millimeter stent is in the iliac vein, and that, you know, you can't take that back. But if you've had a prior stent that, let's say, was a 14 or a 16, I want to get as close to that 14 as possible. And I think ballooning and suction thrombectomy never really allowed me to achieve the stent diameter, the original stent diameter, to then feel better about revising it if there was good inflow and outflow. I think this stent allows me to core closer to the stent itself, the native lumen of the stent. Now, the indication for this device, it's not for acute, I guess, in terms of safety. This device is currently indicated for stents that have been in at least for 6 weeks. You want to have them at least have good apposition to the wall. You don't want to really do this in a stent that's younger than that, if you would, or have been placed more recently, because you can move the stent and cause injury. So there are going to be a set of rules that are currently in place to use this device safely. And certainly as we start our registry, which is the Revcore registry, we'll find out even more ways to allow this device to be used safely and effectively. But I think this device allows you to really core out, if you would, the thrombus. Now, acute thrombus, subacute thrombus, and more chronic material, I think that this device will also allow us to work within the spectrum of different chronicity and aging of thrombus, where we haven't really had good options to date.
So I like the fact that this is primarily a mechanical thrombectomy. You're really taking out whatever's inside the stent. And some of the material that you got out on this patient looked like it was somewhat subacute to, it was somewhat white. It wasn't all red, soft, mushy clot. So this might have a unique advantage as compared to some of the other technologies where you're actually taking out that chronic subacute or fibrotic in-stent problem. So that looks really exciting. It looks really good.
Yeah, and this is the material that just was still layering on the approach reef sheath, which again I think is important to use with these patients, because you want to capture it and remove it. Other cases I've removed more subacute, more collagen-based material, so more aged thrombus, if you would. In this case, I captured him within a week of his acute DVT. So he had but he'd had this device in for 5 weeks prior to that. And so he was already probably layering. It had been layering, and probably from that poor low flow state, just by the angulation of that stent in the pelvic curvature, that probably induced a state of low flow or poor flow through the stent, and had been probably layering since the stent was placed. And so that was my challenge. One is revising it, and then what to do with the other side, because he presented with a bilateral problem. Luckily, the other leg is not post-thrombotic at this state, and he's never had a DVT on that side, but I was hesitant to leave that alone.
This really looks like an advance in terms of our abilities, and yet another tool in the armamentarium of patients with iliofemoral thromboses. I think this will really help push the field forward. So thank you, and I'm looking forward to hearing about some more of the data coming up with this new device.